Good morning. Thank you guys for having me. It's a pleasure to be here. So we were asked to do this talk about how we manage symptoms in our patients with AMN. We're just going to do like a general overview because we see adults and pediatric patients at our center. And we'll also talk about how we run our clinic. So I'll start there. All right, so first I'll start with our mission. It's to improve the care of individuals who are affected by leukodystrophies in early childhood all the way up until adults. And we have a vision to combine cutting-edge techniques in neuroimaging, genomics, biomedical engineering, and nanotechnology to develop new diagnostic tools for therapeutics in leukodystrophies. We also aspire to provide the best possible comprehensive care to our patients with leukodystrophies through an interdisciplinary approach. So our center is a certified leukodystrophy care network center. Certification requires that we meet several standards, including a multidisciplinary approach, with an established core team of providers, the use of the LCN and current best practice care guidelines, and participate in monthly care coordinated meetings and conferences. And we also offer telehealth options for our patients as well as research opportunities. And on the next slide, you'll see our team here. So we have our neurologist, our physical therapists, our rehab medicine team, palliative, endocrine, the list goes on. But, and some of our colleagues are also in the audience today. And this is just like we can actually have appointments with our patients with all of our care team members. And they also do research as well. All right, so there are different types of visits. The largest is our multidisciplinary clinic. In addition to our multi-D clinic, sometimes patients will be scheduled with our neurologists as well as our genetic counselors, or they will have, which is new to our clinic, our newborn screening clinic. And these patients are usually tracked from newborn screening, and then they come into our clinic and they'll see neurologists as well as myself and our genetic counselor. And we can also have pediatric endocrinology see them as well. So on the next slide, I'm going to talk about how we determine which clinics patients should go to. So the patient or referring provider will reach out to our clinic coordinators or express to our nurses that they want to be seen in our clinics, and then the coordinators or the nurse coordinators will gather all of the pertinent documents, including past genetic testing, lab results, clinic notes related to their diagnostics, as well as bring MRI information, and we'll go through it and we'll determine which clinic they should be seen in. And on a few slides, I'm going to talk about how we're kind of changing that a little bit. So this is our multidisciplinary approach. As you can see, we can have one patient come in at like 8 a.m. to see neurology, and then following that, they'll also see our genetics counselor, rehab team, and if they are interested in research, we'll also have them see our research coordinators to talk about participating in research. Patients stay in the same room, and then we rotate in and out of the rooms as we see the patients, and we'll have, we'll chat about what we think is best, how can we get the patients involved, any research that they may be interested in or qualify for, and that is how we usually run our clinics. So patients in the leukodystrophy clinic are typically seen annually, but in the meantime, we might see them for shorter periods, so like every 3 to 6 months. Between visits, they have access to our team through MyChart, or they can call us or send us an email if they need anything in the meantime. And referrals for services can be provided as needed between visits as well. So if they needed a referral to see a physical therapist or another discipline, we would also send referrals out for that. Our team will also collaborate with the patient's local providers, because we have a lot of people coming in from different states, and we'll talk to their providers that are local, just so they are able to provide adequate care for our patients if it's not their specialty. So this is fairly new to our clinic. Last year we implemented the ALD Healthy Planet dashboard, and it's through our electronic medical record Epic. This is a collaboration with CHOP. So the dashboard tracks all the standards of care time points for our ALD patients and our newborn screening patients. So it tracks like your brain MRIs, labs, their next appointment if it's coming up. So if you can see like in green, that means they're on schedule for their ACTH or their next brain MRI. If it's yellow, they're getting kind of close to when it's due next. And then if it's red, that means they're out of that window, and we should be following up with that patient prior to it ever being red though. So we also have some reoccurring active studies we have going on. Calyx, you guys heard about that clinical trial already just previously from the last speaker with leukodystrophy. It's for the adult men with cerebral ALD. We also have the basic transient science study and a few other ones that are ongoing, the AMN clinical biomarker, LBSL, myelin disorders, and the home exercise program for patients with our physical therapist, Jen Keller, which a lot of patients really enjoyed. All right, so as I mentioned before, we are in the process of automating patients coming into our clinic, and they are able to kind of figure out what clinic they should be placed in automatively. So it allows new patients to schedule their own multidisciplinary visit, and if there's like an urgent matter, they can kind of schedule that too. But we're in the process of it. It's not fully rolled out at this time. And this is how the patients will determine which clinic they should be placed into as they answer some questions about what symptoms they're having, what diagnosis they have, and it'll kind of determine what clinic they should be placed in. And it gives it a more streamlined process. So this is the mapping. You don't have to read all of this. It's very small print. But this is how it's mapped out for which providers they should see, what's recommended, what symptoms they're having, and that's how we'll be determining what clinic they should be streamlined into without having to call or without having to send an email. So we'll be taking a crawl, walk, then run approach. So phase 1 will be request the entry decision tree, which is what you guys saw on the previous slide. That's like the decision tree. And it's by the care center staff to triage an appointment request. This phase is intended to do a live proof of concept of triage criteria that we've already defined. And then we have phase 2, which will be self-triage decision tree, where patients can fill out the information themselves and generate an appointment request without intervention from the care center, so without having to call us. And then we have phase 3, which will actually allow the patients to schedule the appointment. So now I'm going to move on to symptomatic patient care. So as we know, patients with AMN, they have some sensory loss, they have progressive weakness, spasticity, poor balance, bowel and bladder dysfunction, and some cognitive dysfunctions as well. So we try to help as best we can with all of those symptoms. So we have rehab medicine that will help with strength training, flexibility, and endurance. We also have like the exercise study that patients participated in to help with improving their balance and strength training. We have medication management, so for spasticity in particular, a commonly used medication is baclofen. It's usually tolerated pretty well, and we start at low doses and can titrate upward and make changes if necessary for patients. And then for neuropathy symptoms, we usually start with something like gabapentin as the first line, and that usually helps patients with the tingling that they have in their peripheral nerves. Some other things we can do, patients often complain about sleep and pain, so there are a lot of scales we use to assess pain and sleep for children and adults. And with management, we can send them to sleep medicine clinics to do a full assessment of maybe they're having restless leg syndrome. Pain management, we can also start like NSAIDs or acetaminophen, and just kind of guide patients through how we can manage their pain that they're having and make it really tailored to them. Seizures is frequently seen in early onset leukodystrophies, but also can be seen in juvenile and adults. Seizures can occur at any stage of the disease, but tend to be more refractory in advanced stages. So we want to make sure we're managing seizures for our patients. If they're having them, we'll get EEGs, and we have like a low threshold, so we can make sure that our patients are developing well with their language and cognition. So you want to, send patients to have neurocognitive assessments if necessary to see where their development is. And then we also have developmental pediatricians who can help with those assessments, and we can make sure we're intervening at an appropriate time. So we want to recognize that severely disabled children with cognitive impairment have higher incidence of pain, so we want to make sure we're doing good pain assessments, neurological exams at every visit, and surveilling for any neurological concerns. We also will have palliative care be involved early in the disease course to help families with coping and support. We want to be sure that we're screening for sleep disturbances, pain, seizures, cognitive development, and difficulties that should be discussed at each visit. And we want to be sure that we're implementing any treatments, modalities that are effective for our patients. So what we find is successful at our clinics, but certainly not perfect, is that we are dedicated clinic coordinators and our nurses. They all help us make sure that we're able to run our clinics smoothly. We build relationships with other providers and industry folks, researchers, and then we have our multi-D encounters and the electronic medical record, which will be streamlining soon so patients can get themselves scheduled as well. And institutional buy-in, by that we mean, just having good collaborations with other folks and making sure we get prior authorizations for everything we need, or single case agreements if we're not participating with their particular insurance. And here is our contact information, and thank you.
Thank you so much, Lachelle. It's really good to hear about how you help the adults and the children at Kennedy Kruger. Has anyone got any questions for Lachelle? think it's pretty much the same kind of model as we have in the UK, and it's good to hear that everyone is sort of doing the same thing, as it were.